My name is John Pandolfino. I am the president of the American Neurogastroenterology and Motility Society, and it's really my pleasure tonight to bring you to the ANMS virtual symposia focused on pelvic floor dysfunction. As you know, that we've been working together with Pediatrics, and really the mission of this is better together, bridging the divide with pediatrics and adult GI motility disorders. I also have the pleasure of introducing one of my former residents at Northwestern, as we discussed before we opened up the meeting tonight, Erin Toto, who currently is an assistant professor of clinical medicine at the University of Pennsylvania. Her practice focuses primarily on motility, including pelvic floor dysfunction, with a special emphasis on women's health and GI. So without further delay, Erin?
Thank you, John. And hello, everyone, and welcome to this edition of ANMS's monthly webinar, Better Together, Bridging the Divide Between Pediatrics and Adult GI Motility Disorders. This month, we're focusing on pelvic floor dysfunction. We have three excellent speakers for you, Dr. Leila Neshatian, Dr. Adil Bharucha, and Dr. Sam Nurko. First, a few housekeeping items. Each speaker will present for approximately 15 minutes, followed by a Q&A at the end of all three sessions. Any questions or comments can be entered into the chat box and will be presented by me during the Q&A session. Please specify which speaker you would like to respond to your question so I can direct it accordingly. Any questions not fielded during the Q&A session, or if we run out of time, will be continued at our ANMS community site, docmatter.com/ANMS. This website's a benefit of ANMS membership, so please sign up if you haven't already. First up is Dr. Leila Neshatian from Stanford University. Dr. Neshatian is the GI director of the Pelvic Health Center and specializes in gastroenterology, neurogastroenterology, and motility, as well as pelvic floor disorders. Her clinical and research interests include a multidisciplinary approach for the care of patients with pelvic and functional bowel disorders. Her research also focuses on understanding pathophysiology of functional defecatory disorders and the utility of pelvic ultrasound for the assessment of pelvic floor disorders. Dr. Neshatian?
Okay, thank you for the introduction and having this platform to discuss about pelvic floor disorders along with my mentors and my esteemed colleagues. So I will, let's remind you that the functional defecatory disorders are one of the few functional GI disorders that require testing for their diagnosis. And we know that the symptoms such as the feeling of incomplete evacuation, the need for digitation, the feeling of anal blockage and straining are not enough to distinguish between patients who have or don't have functional defecatory disorders. And because of that, the Rome 4 criteria recommended that these disorders be diagnosed when 2 of 3 physiologic anorectal tests are abnormal. Given the diversity of the factors that are involved in normal defecation and the fact that the pathology of these disorders are often multifactorial, it's not really surprising that there is no one single gold standard diagnostic test to diagnose functional defecatory disorders. Not to mention that the agreement among these tests are also not the perfect agreement. I acknowledge that many of people may argue that the clinical examination alone is adequate for the stratification of treatment, but I think there is enough literature to support that assessment of functional defecatory disorders can really influence the clinical decision making. And in patients who have refractory symptoms and do not respond to the conservative or medical therapies, these tests should be utilized for the assessment of anorectal structure and motor and sensory function, because they can really help us to augment our understanding of the underlying etiology and establish a diagnosis to which the treatment can be more really optimally directed. So that's why I will be talking about the anorectal manometry today. I will be touching base on balloon expulsion test, the defecography, and finally about the ultrasound in the diagnosis of these problems. Let's start with the anorectal manometry. This is the best well-established and most widely available test that we have in the diagnosis of the pelvic floor disorders. It enables us to measure the intraluminal pressures dynamically. It evaluates abnormal anorectal evacuation patterns such as paradoxical contraction. We can see the presence of dyssynergia, inadequate propulsive forces, anal sphincter pressures at resting and during squeeze. And also it can determine the presence of reflex functions and rectal sensation. Although conventional anal manometry using a water perfused system remains in clinical practice, most centers have used the high resolution anorectal manometry. And within the paradigm of high resolution manometry, the two technologies that are currently available include high resolution anorectal manometry and 3D high definition anorectal manometry. Both of these can present the data either topographically in color plots or as an average of the circumferential pressures. ARM has been used for many years now without any standardization in protocol, and the catheters are used at various centers with different catheters. More recently, the International Anorectal Physiology Working Group provided the framework regarding the indications, applications, and the clinical interpretation of the test under the London classification. And this standardized protocol, you can see on the right-hand side, that is providing the guide about how to perform this in the clinic. The anorectal pressures during simulated evacuation are useful for classifying patients with dyssynergic defecation. Abnormal defecation increase in the rectal propulsive forces along with the anal relaxation will lead to a proper evacuation. It's intuitive that defecation may be impaired because of the weak propulsive forces or increased resistance to evacuation, or if both of these are abnormal. So there are indeed 4 patterns of dyssynergic defecation that have been defined based on the findings of the manometry. Paradoxical contraction of pelvic floor muscles with normal propulsive forces will result in RAO type 1. Impaired rectal propulsion with paradoxical contraction is known as type 2. In type 3 dyssynergia, increased rectal pressure with incomplete relaxation of anal sphincter is seen, and in type 4, there is neither increase in rectal pressure or relaxation of anal sphincter. It's really not clear whether these abnormalities reflect similar or different pathophysiological mechanisms. Also, despite the interest in this classification, it's really unclear whether the patterns can discriminate among healthy people and patients with constipation or with functional defecatory disorders. So in an effort to answer this question, on how to differentiate constipated patients with or without evacuation dysfunction, a PC analysis was used in this study and integrated high-resolution manometry variables into different phenotypes. The 3 phenotypes that discriminated between a patient with normal balloon expulsion test or prolonged balloon expulsion test were characterized predominantly by high anal or dyssynergia, low rectal or low propulsive forces, or hybrid, which included impaired anal relaxation during evacuation and also diminished rectal pressures. As you can see, the rectal pressures increased only in the high anal phenotype, and the anal relaxation was normal in the rectal phenotype, but it was absent in the high anal and the hybrid pattern. Also to remind you that the anal tone was elevated in the high anal. So many other investigators also have been working on the methods and the ways to increase the diagnostic accuracy of the anal rectal manometry. In this work, we looked at whether rectal distension to 50 or 100 cc at simulated defecation will affect the pattern of dyssynergia. And we know that this is not typically seen in, in normal controls. And we found that rectal balloon distension at simulated evacuation improved the recto-anal gradient and decreased the rate of dyssynergia. And this was more prominent in patients who had normal balloon expulsion tests and patients who had also normal rectal sensation. So we showed that 50 ml of distension seems to be optimal as compared to 100 cc. Of course, this was a small study, and future larger studies with respect to healthy controls are also needed to be conducted. And I want to also mention that the current London protocol does not really recommend distension of the rectal balloon for simulated evacuation. The other critique to the arm has been the fact that it's normally performed in the left lateral positions. And many have looked into this before, including this study that came recently. And in this study of high resolution manometry, the logistic regression model was used to compare the effect of position on discriminating between the constipated patients who have normal or abnormal balloon expulsion test. And the recto-anal gradient in the seated position was shown to be more effective than the corresponding left lateral gradient for discriminating between patients who have normal or abnormal balloon expulsion test. So position seemed to be important in enhancing the utility of anorectal manometry for the diagnosis of functional defecatory disorder as well. In this study, there were a lot of more sophisticated information about how to read the manometry, how to obtain the gradient. And I want to encourage everybody to read these, but I don't have the data to or time to show you here. Let's talk briefly about the balloon expulsion test, which measures the time that needs to expel a balloon that is placed in the rectum. The upper limit of normal time to expel the balloon varies across different studies and have been reported between 1 to 5 minutes. In a recent systemic review and meta-analysis, they suggested to use the cutoff time of 1 minute, which was associated with an AUC of 0.8 in the diagnosis of dyssynergic defecation. Here we have the test that can determine the response to treatment, and it's been shown that it can predict a positive response to biofeedback and can be used for determining that in the clinical practice. Let's talk about the defecography. The barium defecography or the MR defecography, they can assess both the anatomical and functional abnormalities of the anal rectum. The technique for the barium has been really not applied without variation in different centers. We don't really know about the position of the patient, the bowel preparation, consistency of the contrast material, and type of the radiolucent commode that has been used in different studies. They have not been ever consistent. On the other hand, more recently, the defecography has been conducted by the means of MRI. And it has the advantage of simultaneously assessing the pelvic floor compartment on 3 levels. And there is no ionizing radiation. And MRI defecography is usually done in the supine position, which is not ideal. As you can see, the normal values for the anorectal angles and motion have been defined. It has been shown that these are different among the younger patients, as you can see in the top panel, as compared to the older patients in the lower panel. And again, this seems to be a great test for evaluation of both function and the structure of the anorectal compartments. The question that has been always proposed is whether MR defecography or the barium defecography has the superiority over the other. And this graph shows that pooled prevalence of 5 comparative studies for specific finding according to the radiologic technique is compared. And you can see that the pooled prevalence showed that barium defecography in blue was superior to MR defecography in red in detection of the intussusception, but this was also less poorly tolerated and associated with the higher levels of embarrassment among patients. Otherwise, there seem to have a really high agreement in the assessment of other structural and functional pathologies as compared together. So because of the fact that they can show both functional and structural pathologies, some have suggested that they should be considered as the first line diagnostic test for the assessment of patients with functional defecatory disorders. And the question is whether gastroenterologists should really give up on the anorectal manometry. Of course, we'd rather explore to learn from high-resolution manometry from the patients who had the structural pathologies. In this large cohort of patients with symptoms of obstructive defecation, they found that the agreement between the high-resolution manometry and defecography was really significant. And they also noted that patients who had a narrow band of high pressure at the time of the simulated defecation, they had a significant rectocele or anal intussusception in the MRI when they looked at the imaging. So high-resolution manometry may also suggest the presence of structural anomalies based on this study. But not only that, but it can also show and identify the different phenotypes of patients who have rectal prolapse. The two phenotypes that are described, one was correlated with a higher anal pressure at rest and during the squeeze and significant dyssynergia. And this was associated with a small prolapse. And in the second model, there was the decreased or diminished anal pressure at rest during the squeeze. And there was also a greater rectal anal pressure gradient during evacuation. And it was associated with a large rectal prolapse, which is as a result of the stretched anal sphincter and abnormalities that we can see in the anorectal manometry. So you can see that we are learning how to interpret the high resolution manometry even better according to the structural pathologies. What about the ultrasound? I want to remind you about the echodefecography, which is performed with a 3D ultrasound device. These high-resolution probes with a 360-degree transducer and built-in 3D imaging is ideal for visualizing the rectal wall layers and anal sphincter. The technique has been shown to be reproducible, and the prospective multi-center studies have shown that the echodefecography correlates well with the conventional defecography. As you can see in these images, the different layers of the internal anal sphincter, external anal sphincter, and the puborectalis can be really seen clearly along the length of the anal canal. But I feel that this is a less explored field for us in gastroenterology and has great potentials. It can show us the structural pathologies such as the rectocele. It's usually obtained in the left lateral position with some gel as the contrast in the rectum. And in normal patients during the straining, you can see the posterior vaginal wall maintains a straight horizontal position during defecation. But in a patient with a rectocele, the significant bulging of the rectal wall happens into the vagina. And by measurement of this rectocele, we can definitely identify the pathology. To the same token, we can see the presence of intussusception, which is clearly identified by observing the rectal wall layers protruding through the anal lumen. Above that, we can use this technique to show the anorectal functional abnormalities. And here, the angle between the internal edge of the puborectalis and the anal canal axis is measured. And this can produce the angle at rest and during the straining to determine whether the puborectalis muscle relaxes during the defecation. So normal relaxation is recorded if the angle increased by a minimum of 1 degree. And if there is abnormal contraction of the puborectalis, you can see this angle closes. And these findings have been shown to be correlating very well with the anorectal manometry finding. And we have been also working to correlate these findings with a high resolution manometry. And I think there is a lot of potential here to work, and it can be used as a point of care, and the expenses are low and well tolerated by the patients. So putting all these together, let's get back to the London classification. They proposed 4 parts and address the disorders of the anorectal inhibitory reflex, contractility, coordination, and sensation. Because I was tasked to talk about dyssynergic defecation, I reviewed the disorders of coordination here with you. As you can see, the findings are defined as major, minor, or inconclusive, similar to what we have in Chicago classification. A major finding is the pattern that is not seen in control subjects, and it's likely to represent a physiological alteration that is associated with the symptoms. And I must point out that none of the abnormalities of coordination are considered to be major findings. Even the patients who had abnormal rectal evacuation with dyssynergia, with abnormal propulsive forces, or both, these are considered as minor findings, meaning that they can also be seen in healthy controls. And if the patient has only abnormal rectal evacuation with normal patterns of manometry, or if they have abnormal evacuation with normal patterns of manometry, they considered as inconclusive findings, meaning that these are of unclear significance and have to be determined further. So in conclusion, despite the challenges that are involved in analysis and interpretation of anorectal tests, they can provide a mechanistic understanding of anorectal pathophysiology, which can direct the effective management. The International Anorectal Physiology Working Group protocol with the London classification of anorectal disorders provide a much needed framework for us clinicians, and future studies are needed to determine the clinical utility of anorectal investigations in directing patients' management. Thank you.
Thank you, Dr. Neshatian, for that excellent presentation on defecatory testing. Next, I'd like to introduce Dr. Adil Bharucha from the Mayo Clinic. Dr. Bharucha's research, which is supported by the NIH, is focused around 4 major themes: anorectal and pelvic floor disorders as manifested in obstructed defecation and fecal incontinence, colonic motor dysfunction and chronic constipation, diabetes-related diseases of the intestinal tract, such as diabetic gastroenteropathy, and functional dyspepsia. He is participating in a multi-center trial comparing biofeedback therapy, sacral nerve stimulation, and perianal injection of dextronomer for fecal incontinence. Dr. Bharucha.
Thank you very much, Erin, and I'd like to take over from where Dr. Neshatian left off. I have these disclosures, but they're not germane to my presentation. And as Dr. Neshatian very nicely shared, the fact that defecatory disorders come in different flavors. By contrast to this normal pattern where evacuation is associated with relaxation of the puborectalis, increased intrarectal pressure, opening of the anal canal, and ultimately expulsion of the ultrasound gel, some patients with pelvic floor dysfunction or defecatory disorders struggle to evacuate stool from the rectum. You can see that the pelvic floor is relatively frozen. This lady is trying because you can notice the furtive abdominal expansion, but despite that, there is virtually no evacuation of the gel. By contrast, at the other extreme, you have patients like this who have marked perineal descent, a large rectocele, a large cystocele, and so they expel the gel, but at a price, the price being marked weakness of the pelvic floor. And it's obvious that one size will not fit all when it comes to managing these patients. Nonetheless, pelvic floor biofeedback therapy is the tried and tested option that typically works in approximately 60 or 70% of patients. When it doesn't work, or if you don't have access to biofeedback therapy, then one has a variety of fallback options, the efficacy of which is unclear, and we'll come to them. And then there are what I consider the do not use options, even if you're encouraged to try your very best, and that is sacral nerve stimulation and subtotal colectomy. I would not under any circumstances offer a subtotal colectomy for a patient with a defecatory disorder. This slide summarizes the challenges to the diagnosis and management of defecatory disorders. As Dr. Neshatian pointed out, whilst the diagnosis is generally evident, some patients fall in the gray zone. That is, either one is not sure if they have a defecatory disorder, or if they do, the extent to which it is causing the symptoms. There is no gold standard diagnostic test. Arguably, a prolonged rectal balloon expulsion time is the most sensitive and specific test. We all recognize that it is very challenging to replicate defecation when lying on the side in a laboratory. Hence, false positive tests are not uncommon, and one has to interpret the test results in the context of a patient's symptoms. Pelvic floor biofeedback therapy is the cornerstone of therapy, but the techniques are not standardized, and this is truly a blend of art and science that is influenced by the relationship and the rapport between patients and therapists, and is not widely available. And there are few effective options for patients who fail biofeedback therapy. So the algorithm essentially begins with manometry and balloon expulsion tests. If these tests are normal in a patient with a low clinical index of suspicion, or at the other extreme, abnormal in patients with a high clinical index of suspicion, then you're home free. By contrast, if there's a discrepancy between one's index of suspicion and the results of these tests, or if you suspect pelvic organ prolapse, then a defecography is necessary to break the tie, particularly in patients with excessive perineal descent or pelvic organ prolapse, where the balloon expulsion test is often normal. Biofeedback therapy begins by encouraging patients to assume an appropriate posture and practice diaphragmatic breathing while seated on the cupboard. And then patients learn to generate an adequate push coordinated with relaxation of the external anal sphincter. And throughout this, they receive feedback of the activity of the anal muscles, hence biofeedback, either through surface EMG or with anal manometry. And needless to say, like everything else in life, it requires repetition and reinforcement. So you can see this patient appropriately increased rectal pressure, but inappropriately increased anal pressure before biofeedback therapy. But after she had the biofeedback therapy, she now appropriately relaxed the anal sphincter, thereby establishing the recto-anal gradient necessary for evacuation. And therefore, it's not surprising that in these three pivotal trials, total of 260 odd patients conducted in Italy, Chapel Hill, in Iowa City, with endpoints that varied, from grading symptom improvement to a phone call from the investigator to patients asking them if they had adequate relief of symptoms or another VAS scale. In general, biofeedback therapy was better than the control arms shown here on this slide. And Anal dyssynergia, and in some studies, rectal balloon expulsion time also improved in these studies, again supporting the efficacy of this approach. Nonetheless, the Cochrane review, which generated some controversy, raised some questions, some of which were appropriate about biofeedback therapy. They reviewed 17 eligible studies with a total of nearly 1,000 patients, most of which compared biofeedback to non-surgical therapy. They pointed out that the eligibility criteria were variable, albeit most patients had dyssynergic defecation. The variability in techniques used to provide the biofeedback therapy, the schedule of biofeedback therapy, identified the high risk of bias related to blinding. It's virtually impossible to blind someone to biofeedback therapy, and concluded with the statement that the evidence was low or very low, and suggested, perhaps appropriately so, that more evidence was necessary. And perhaps it's time now or in the near future to conduct a large-scale multi-center trial of biofeedback therapy with patients in primary care, not just in secondary and tertiary care, who've received a standardized diagnosis, are treated with a standardized approach, and a standardized assessment of outcomes. On the other hand, some of the limitations pointed out here are virtually impossible to control for an intervention such as biofeedback therapy. Many physicians don't have the access to biofeedback therapy. To those of you who don't, I'd encourage you to go to these websites and look around. I think there are many pelvic floor therapists who provide therapy, but this is not the same as providing specialized biofeedback therapy for defecatory disorders. Dr. Rao runs a workshop at the University of Augusta in Georgia every so often. Unfortunately, many insurance companies don't cover biofeedback therapy, and pre-authorization does not guarantee coverage if the policy itself does not cover the surface. So that begs the next question, is home therapy an option? And Dr. Rao did this study comparing home to office-based therapy in approximately 100 patients. For the home biofeedback therapy, patients were instructed to use the device in person at one visit, and then they went home. This was a dual probe sensor which had measured both rectal and anal pressures. They were taught how to place the probe, sit on a commode, and then perform these maneuvers whilst monitoring pressure changes on the device. They were encouraged to practice this twice a day and record the results. No, this was not on Zoom. This is probably one thing you couldn't quite do on Zoom. They were asked to return to hospital for follow-up visits after 4 and 8 weeks. And to cut a long story short, approximately 2/3 of patients were responders with the home biofeedback therapy, and this was not inferior to the office-based biofeedback therapy, but the probe is not available, nor is there a substitute on the market. So that begs the next question, well, what does one do if you don't have access to biofeedback therapy or your patient hasn't responded? And we covered this in this nice review in NGM 2 years ago. And these are the options, and I'll quickly make my way through them. It stands to reason that laxatives might be beneficial because it's easier to evacuate soft and hard stools. You can use whatever works for yourself and your patient. Remember that defecation is preceded by high amplitude propagated contractions, which are induced by bisacodyl and glycerin suppositories, which often work if given 30 minutes after a meal on an as-needed basis, supplemented by enemas. And you can also opt to use a serotonin 5-HT4 receptor agonist. You all recognize that none of the pharmacological trials in chronic constipation effectively excluded patients who had pelvic floor dysfunction. Transanal irrigation is a fancy name for enemas. You can use, they've used a variable amount of water with or without a device. In the systematic review, approximately 50% of patients did better. Another review addressed outcomes more formally with outcome questionnaires, and you can see the numbers ranged in this 40 to 60% range. And the baseline characteristics, age, duration of constipation, features of obstructed defecation, and colonic transit time did not predict the response. I think we all advise our patients to use enemas on an as-needed basis, and they're probably safe. More recently, one has access to these transanal irrigation systems. This is one that's just shown on the slide. It has to be replaced every 6 months. The catheters are meant for single use, but I know some patients who use them more than once. They're apparently available for a cheaper price on eBay, and the company assists patients with their paperwork. Might it help to defecate in the squatting position? Well, in many cultures, people do evacuate in the squatting position. Another way to accomplish this is with this footstool. And supposedly, squatting relaxes the rectoanal angle and also the pelvic floor, thereby enabling defecation. There's one study in 145 medical residents and their family members who were asked to record their bowel satisfaction before and during the use of a footstool. You can see here in the right panel that some of these participants said that they felt it was easier to evacuate when used with rather than without a footstool, but this is an unvalidated questionnaire. These patients didn't really have constipation. So we are conducting a randomized controlled trial of a footstool for constipated disorders. A percutaneous endoscopic colostomy is similar to the Malone enema device for fecal incontinence. Essentially, the tube is placed via colonoscopy through the abdominal wall into the cecum. It was initially used for sigmoid volvulus and patients with chronic intestinal obstruction. There's several reports. Again, we've summarized this in this review paper right here. By and large, it works reasonably well. The patients who died for reasons that was unrelated to the cecostomy. The common complications were what you'd expect: chronic pain, granulation tissue at the stoma site, and infections. It's a relatively low-risk procedure, but the question that I have in my mind is, in a patient with pelvic floor dysfunction, do you really want to flood the colon with a large volume of water? Because if you have severe pelvic floor dysfunction, regardless of the composition of the effluent, it's going to be hard to evacuate. So this is not something that I've used. What about Botox? Well, in this systematic review, they started out with 169 records and only ended up with 11 that could be included in the qualitative synthesis. So that tells you a lot about the quality of the literature. And none could be included, was of sufficient quality to be included in the meta-analysis. And they administered the Botox typically at lateral side with a variable dose, either with palpation, ultrasound, endoscopy. Some studies administered follow-up injections, and they concluded by saying that the evidence for using Botox is poor and only covers a transanal approach, and further studies are necessary. So this is not something that we use. Some patients with defecatory disorders have a high anal resting pressure, and nearly 70% of anal resting pressure is contributed by the internal anal sphincter, and this is probably attributable to alpha-1 adrenergic receptors. And these alpha-1 antagonists are widely used to treat urinary symptoms in patients with prostate symptoms, but they've never been evaluated for defecatory disorders. And so we explored the utility of alfuzosin, in particular because it's much more specific prostate, and we surmise by extension to the anal sphincter than vascular tissue, and thereby less likely to be associated with orthostatic hypotension and syncope. So we started out with an acute treatment where patients, underwent an assessment of anorectal pressures before and after they received alfuzosin and placebo, followed by bowel diarrhea in the constipated patients. And you can see here, if you compare the top and the bottom panel, that the resting pressures, shades of yellow and red before, but blue and green, so much lower pressures after the alfuzosin, but it didn't impair the anal contractile response because it doesn't affect voluntary muscle. And even the anal pressure during evacuation was lower after than before alfuzosin. So again, to summarize the data on this slide, the effect on anal resting pressure was greater than it was with placebo. The anal pressure during evacuation was also lower with alfuzosin compared to placebo. The rectoanal gradient, however, was not significantly different for alfuzosin versus placebo, perhaps because it doesn't affect the rectal pushing force. And it didn't improve bowel symptoms, perhaps because it doesn't affect the voluntary muscle dysfunction. So sometimes you use it as an adjunct in patients with anal fissure and a high resting pressure. Surgery for defecatory disorders. Many people, not just constipated patients, just many healthy people have a rectocele, especially in the elderly. And small rectoceles may not be the primary abnormality, but rather be secondary to impaired anal relaxation. So if you have a sphincter that doesn't open and you're pushing from above, the rectal wall is bound to give way in its weakest portion, which often happens to be anteriorly. And thirdly, remember that restoring structure does not always restore function. In fact, if you restore structure and the pelvic floor is too tight, it may impair function. And therefore, one typically reserves surgery for patients who have full thickness rectal prolapse or a rectocele, where the symptoms truly suggest that the rectocele is affecting evacuation. I mentioned the STAR procedure only to point out that this is something that's really caught on in Italy, and we should probably not be offering the procedure in the US. So I'm going to end with the same points, reminders about the management of defecatory disorders. Thank you all for coming today. I look forward to your questions. Thank you.
Thank you, Dr. Bharucha, for that thorough review of management options of defecatory disorders. Last but not least is Dr. Sam Nurko from Boston Children's Hospital. Dr. Nurko is the director of the Center for Motility and Functional GI Disorders at Boston Children's Hospital and professor of pediatrics at Harvard Medical School. He is also a member of the Rome Foundation Board. His main research interests are in the areas of mechanisms of defecation and fecal continence, postoperative problems after GI surgery, gastroparesis, and disorders of the brain-gut interaction. He's actively involved in a number of clinical trials and outcomes research studies. Dr. Nurko.
Thank you, Erin. First, I want to thank the organizers for allowing me to participate in this symposium. I think it's a great opportunity for us to bridge, between pediatrics and adults. And we're going to focus today on the defecation, the approach to defecatory dysfunction in pediatrics. And I know Dr. Garza presented a few weeks ago a whole talk on pediatric constipation. So I'm going to try to really build on what Dr. Garza had presented. So I want to say I have one disclosure that's not pertinent to the present presentation. And today I'm really going to talk about what do we consider defecatory pelvic problems in pediatrics? Do we know anything about their prevalence? How we diagnose them? And more importantly, what's the therapies we use for these particular disorders? So I just want to remind people that constipation is a very common problem in pediatrics. Systematic reviews show a prevalence of around 9.5%. And I brought this slide on purpose to show you that the reports vary between the age and the gender, but there's no question that in pediatrics, we deal with a lot of young kids. that have the highest prevalence and a lot of the problems we deal with. If you see, it represents 3% of the visits to the general pediatrician, given the age of the patients and issues related to toilet training. But in pediatric GI, it's at least 25% of the patients, and it's very common and frustrating. The parents always think there's something very wrong, and it's very dangerous. The quality of life of these children is low. So what do we know about the pathophysiology, and why is this relevant to pelvic disorders? We know that the pathophysiology in children is multifactorial. And clearly in pediatrics, we deal with all the developmental aspects of toilet training as children are growing up. So even though adolescents are very similar to adults, the young children are very different. And the thought process now is that constipation in most children starts with the purposeful or subconscious withholding of stool. This is a normal developmental phase. But then they start to develop pain. And once they get pain and painful defecation, they start to withhold even more, and they are very afraid of moving their bowels. The retentive child learns to contract the pelvic floor, the anal sphincter, and the gluteal muscles, as you can see in this picture of a patient. We call it the duty dance. And parents think that patients are pushing and trying to defecate, but it's the opposite. They are really trying to withhold. And this creates a circle in which there's a vicious circle of dyssynergic defecation. Patients don't evacuate completely. We start to have fecal impactions, and we start to have overflow incontinence with impaired rectal sensation and a loss of the normal urge to defecate. And this is the cycle that we deal in pediatrics a lot in most of the patients that we see. The ROM criteria have tried to address this problem, and our ROM criteria are a little bit different from the adult ROM criteria, as we have to take this into account. You can see that we have criteria for the young kids, as they are not toilet trained, and it's different. And then we have criteria for the older kids, more than 4. But what I wanted to show is that, similar to adults, we've moved away from focusing on defecation numbers per week. And at least in pediatrics, is very important. We deal a lot with incontinence, which is not a criteria that you find in adults. And the history of retentive posturing and withholding behavior is part of the ROM criteria. So right away, if you look at the prevalence of this, and this is a study that used the ROM 3 criteria, which are very similar, as I don't have anything similar for ROM 4, only 39% of the patients diagnosed with constipation had an abnormal frequency. Most of the other ones had either fecal incontinence or retentive posturing, right away suggesting to us that the withholding behavior is very important. And the corollary should be, wow, this means that pelvic problems have to be very important because the kids had withholding, which is related to the pelvic function. It's interesting for you to see that we do not divide the pediatric constipation into groups. We do not have different criteria for anorectal dysfunction and functional constipation. We just have a continuum in which all the children are adapted to, and this is very important to know. And I also want to point out that all the clinical drug trials in children, and even though I'm not an adult expert, all the adult trials I know from most medications in adults do not really stratify for the defecation abnormalities and the pelvic floor dysfunction. They include all comers. And there's even studies where they subclassified, and they see that certain things like prucalopride may be more effective in patients with pelvic floor disorders in adults. So this classification, even though it's there and even though it's important, may not be as significant as we think, particularly in pediatrics. So I'm gonna start to be a little bit provocative and try to address the questions, right? Does pelvic floor dysfunction really exist in children? Can children learn how to relax the sphincter if they have this pelvic floor dysfunction? And if they do, does that change the outcome? So that's the first thing I'm going to address during my talks. Does it exist? I don't have to present the whole pathophysiology, but yes, if you do anorectal manometry and we follow the adult criteria, even with non-high resolution manometry, which are most of the studies we did initially, you can see defecation abnormalities in 40 to 50% of children with functional constipation. Caveat, most of these children were more than 5 years of age, as in younger kids, sometimes they don't cooperate and it's hard to know and they don't understand the instructions. We do not have any pediatric studies that have addressed the types of dyssynergia that have been described in adults. And I don't want to move from this slide without mentioning again, the main indication to do an anorectal manometry in children is to exclude a non-relaxing sphincter Hirschsprung's disease or internal renal sphincter achalasia, not a pelvic floor dysfunction. So, but this is clearly present. What are the pitfalls of using manometry to diagnose constipation? We already heard from Dr. Neshatian the issue about the position, and that has been shown mostly in adults. But the pitfalls in kids is, first, we don't have studies in normal children. The age really changes the way you approach. The cooperation, as I mentioned, younger kids may not cooperate, and you don't want to create a post-traumatic stress in a patient that's withholding behavior and is afraid of defecation by doing an anorectal manometry. That may not change the management. There's clearly an understanding issue here. People need to be willing and understanding of the push and the squeeze, and some studies suggest kids need to be more than 8 years of age. And then we have all the kids with ADHD, autism, all the developmental problems that do not allow us to really do anorectal manometry. And finally, there's two technical issues that I really want to mention in this age of high resolution manometry. We already saw the data. I just want to present these 2 points. If you look at normal volunteers in high resolution manometry in the adults, you see that the prevalence of dyssynergic defecation is very high. This is one study that showed it was present very high as compared to the constipation, no difference, even with the subtypes. And this is a compilation of all the studies, and you can see 80 patients, normal patients, had defecation. So this raises the issue that when we're using high resolution manometry, the defecatory abnormality may not be real. If you add to this the high definition manometry, imagine just the size that this involves in children. We tend not to use this catheter in kids less than 10, and even in kids older than 10, sometimes the pressure can change things. But in adult normal volunteers, you can see the presence of a dyssynergic pattern was very high. And I just bring this for all my pediatric colleagues in the audience and even for the adults, just to remember when high resolution manometry is used or high definition manometry is used, you have to be very careful to diagnose dyssynergic defecations using these very big probes, and particularly the very stiff probe of the high definition manometry. Now, let's assume we do have the diagnosis. Can the children learn how to relax the sphincter? I mean, is this something that we can teach them? And yes, this is a meta-analysis. This was done not with high resolution manometry. You can see here that clearly kids learn how to relax the sphincter, the defecatory problem goes away, and the kids do great from a defecatory point of view. The question is, does that change the outcome? And this is the meta-analysis again, showing that the use of biofeedback in children with constipation did not change according to the use or lack of use of biofeedback. And the sub-analysis showed that there was no difference when you control for those kids that normalize their defecation dynamics and those kids that do not. And the conclusion from this Cochrane review and the ANMS biofeedback group in 2015 was that there was no evidence that the biofeedback training adds any benefit to conventional therapy in the management of functional fecal incontinence and constipation in children. Now, is this why? Maybe the manometry is not the right way. Maybe we need to use other techniques that have been used in adults, right? What about using the balloon expulsion test? Is the transit helping us if we see evidence of outlet obstruction according to the transit or other imaging studies? Most likely, we need to address the fact that all these reflects that this is a mixed problem. You can have pelvic floor dysfunction and transit problems. So what do we know about this? Or are we missing the boat? And maybe these patients have a different problem like non-retentive fecal incontinence. And finally, the question we always get a lot of pushback is, we GI doctors don't know how to do biofeedback. And in pediatrics, most of the biofeedback trials have been done by the pediatric gastroenterologist that's actually, or the pediatrician that's actually doing the training, not a particular physiotherapist. So using a physiotherapist, would that change? So what do we know about the other techniques? And I have to say we have very little information about balloon expulsion in children. There's no standardization. Nobody knows the timing. And clearly in all the studies, it has not been associated with dyssynergia. Here you can see the control subjects. None of them had dyssynergia and all were able to expel the balloons. And the ones that were able to expel the balloons or were not able to expel the balloons, you can see there was no significant difference in the presence of dyssynergia. And in this particular one, you can see again that the balloon yes, there was some abnormalities. Only 7 out of 14 had dyssynergia when they could not expel the balloon, and 2 out of 14 were able to expel the balloon, but they had dyssynergia. So we don't really know, and balloon expulsion is not used the same way as it's used in adults. What about the colonic transit? People wanted to know if doing transit and looking at the outlet obstruction with all the markers in the sigmoid was going to predict who has a pelvic floor dysfunction. And here they use abdominal pain as a control. Here you have non-retentive patients and patients with constipation. And you can see there's no difference in the dyssynergia found by anorectal manometry. And this shows you there's no difference in the symptoms and the transit. So transit time and evidence of the markers in the rectal sigmoid of children does not reflect that you have pelvic floor dysfunction, does not change your therapy. So there's no difference. We know most children with constipation, more than 55% have normal transit. And yes, there's some children with slow transit constipation that may have worse symptoms, and those are picked up by the transit study. What about defecography? We don't have a lot of standards. There's only 2 studies. We don't have real MR defecography prospective studies. But as you can see here, yes, they find some structural abnormalities and things you were not thinking about. But most of the time, there was no association between the defecography abnormalities and the anorectal manometry. Given the lack of cooperation, given all the radiation therapy involved with this is not a technique we use all the time. We tend to use it in intractable adolescents and in patients with evidence of internal prolapse or cloacogenic polyps or solitary rectal ulcer. So maybe we're missing the boat. Maybe there's other diagnostic problems. And I want to bring up, that given the incontinence is so important in kids with constipation, we do have a subgroup that has non-retention and incontinence, and they present with incontinence. This group is very different, depending on the study, varies from 2 to 5% of the prevalence, but they all come to the GI group and they always get treated with laxatives because they think they have retentive soiling. And there's a small overlap here, and these children get treated very differently. The question is, can you use biofeedback to learn how to relax the pelvic floor? And again, this was shown that patients with non-retentive soiling do worse with biofeedback training. What about, do we do biofeedback by a physiotherapist? And there's 2 recent studies. This was population-based study. This is 5 centers in the Netherlands, where actually they compared regular therapy with physiotherapy done by a pelvic floor therapist that included education, abdominal muscle, a very sophisticated analysis. And you can see they achieved a 92% success rate in these patients. Interesting, they were able to enroll only 53 out of 367 they wanted. And when they tried to do defecation abnormalities, most of the parents refused. So we do not know if these patients are regular constipation and what's the rate of pelvic floor dysfunction they have. And there's another recent study that tried to do the same in the community. And this study, there was no difference between the aggressive, physical therapy by physiotherapists and the presence and the control group. So are there other interventions? Dr. Bharucha already mentioned that. In pediatrics, given the retentive and issues, given the difficulty in younger kids, the use of Botox has been used frequently in patients with constipation. This is a recent systematic review, and you can see there's at least 5 studies that have used Botox for kids with constipation with very good results. There's no relation with anal dysfunction, and these patients were not screened for pelvic floor. So this Botox tends to be used in children with severe withholding behavior that are not responding to regular therapy. So I just want to finalize by saying that in the armamentarium of pediatrics, yes, we do education, toileting, reward and bowel diary as a first step. Then we use the osmotic laxatives. Then we start to go to the stimulant and the novel therapeutic agents. So when do we address the pelvic floor dysfunction? We address it once the patients start not to respond to the usual therapies. In adolescents, I do believe there's a value in trying pelvic floor therapy. In younger kids, there's no value in doing that. And then after all this has failed, then we go to the things that Dr. Bharucha mentioned. Also, we use a lot of transanal irrigations, the Botox, and then we start to get more and more invasive until we come to surgery. Thank you.
Thank you, Dr. Nurko, for that fascinating review of constipation in children and highlighting the important differences between evaluation and management between children and adults. So now we're going to move on to our question and answer session. We don't have too much time, but we can go a little bit over. There's been multiple questions actually answered already in the chat box, but I will present the ones that have not yet been answered. One comment was, in pediatrics, it's really challenging, if not impossible, to diagnose dyssynergia in younger children and those with neurodevelopmental disorders. In this group, we have to rely on clinical presentation. Question for Dr. Nurko. Do you think we need anorectal manometry at all for kids? Balloon expulsion test is not enough combined with digital exam?
It's a very good question. I mean, we do need the anorectal manometry. That's the only way to decide if the patient has Hirschsprungs and unrelaxing anal sphincter. Don't forget, like, depending on the series, as about 1% of Hirschsprungs patients can be picked up in adolescents or young adults. So the main indication is to be sure that the defecation problem is not related to an unrelaxing sphincter. I don't do balloon defecation. We did it for a long time and it didn't really add much. But I think if it's well standardized, digital exam is very important and you can really learn a lot. Don't forget, a lot of kids don't let you do it. So my non-committal answer would be probably we don't need to do this in pediatrics at this point.
Okay, I think Dr. Bharucha answered this, but for the benefit of everyone, if we use the normative data for anorectal manometry published this year in NGM, it seems like we will diagnose dyssynergic defecation in only a few patients. How do we reconcile this with the high prevalence of dyssynergia in patients with chronic constipation not responding to over-the-counter laxatives?
Thank you. So this is a good question. And just to underscore the point that conventional concepts would suggest that rectal pressure should be higher than anal pressure during evacuation. However, as Dr. Neshatian pointed out, many healthy people, especially younger women, have an anal pressure that exceeds rectal pressure during evacuation. So when one comes across that finding in a patient, in a constipated patient, it's hard to tell whether it's normal or abnormal. Therefore, the range of normal is what is considered normal is fairly wide. And some patients who might have previously been considered to be abnormal fall into the normal range, as Dr. Nurko pointed out. Therefore, manometry is of limited utility, I think, in the grand scheme for diagnosing defecatory disorders. You can diagnose defecatory disorders in some patients who satisfy rigorous criteria, but there are others who fall in that gray zone where a balloon expulsion test may be much more useful.
Okay, one more question for Dr. Nurko. Are MR defecography studies helpful at all in children?
So as I mentioned, the information is very limited. You know, we collaborate with the adults across the street at the Beth Israel Hospital to do it. I find that it's very useful in intractable patients in which we found mostly colorectal, cloacal polyps, rectal ulcer syndrome, rectal prolapse. That's where we found it to be useful. We don't use it to diagnose defecation abnormalities.
Dr. Bharucha, does rectal hypersensitivity play a role in dyssynergia, and does neuromodulation help improve sphincter relaxation in those cases or make those patients more likely to improve with biofeedback?
It's relatively uncommon to find hypersensitivity in patients with dyssynergia. One comes across it every so often. I guess it's a good question. It wouldn't surprise me if someone who is hypersensitive tended to contract as opposed to relax the anal sphincter. I'm not aware of any neuromodulation studies that have looked at anal relaxation.
Another one for Dr. Nurko. Any efficacy of Botox for autistic children?
Actually, that's a very important question. Given the challenges with autistic kids, that's one of the most common interventions we do in kids with autism that have not responded to the regular therapy. We don't even try the manometry. It's impossible to do. You have to do ketamine sedation. It's very complicated. So yes, we tend to do Botox for these children that have constipation. There's no studies that show the efficacy. My own bias is probably more than half the patients respond very well, and we do repeated Botox injections.
Great, thank you everyone. It looks like we're running a little low on time, so our Q&A session will be continued at our ANMS community site, docmatter.com/ANMS. Join us for our next webinar on Wednesday, December 16th on GI dysmotility, the role of non-neuronal cells. And note, there will be no virtual webinar in January, so please check the ANMS website for the 2021 lineup starting in February. Thank you for your attention and have a wonderful evening.